So first of all, welcome to everybody, and thank you for joining for this session today on that is one of the meetings that we dedicate to HCC. And this afternoon specifically, we're going to address the issue around post-operative liver failure. That is really a big problem in dealing with these patients, or maybe. First of all, I just want to thank the Gastro Foundation and Project ECHO from the University of New Mexico for facilitating this. This is one of the sessions that are held every Wednesday. We do the HCC session every 4 to 5 weeks. Then just in terms of the people that have registered for the meeting today, we've had more than 80 registrations. I'm just looking here at the countries, 16 countries, of which 14 are in sub-Saharan Africa. And I think it's the first time that I see somebody from Angola, so very welcome. You're very welcome. And then there's also people from Spain and the UK that have registered. The chat will be open for any questions that you pose that we'll keep an eye on. And when we come to the discussion of the problems, you're also welcome just to raise a hand or to unmute and just pose a question or a comment. We really would like it to be quite interactive. So it's really a pleasure for me to introduce Dr. Stefan Yield from Karolinska University Hospital in Stockholm. We former colleagues, and he has about 2-3 years ago did his PhD on exactly post-operative liver failure, and we're really privileged to have him. And he's going to give us a short talk just on the clinical, on the diagnosis and the management of post-operative liver failure. I will start just with a quick briefing on the ways that we can try to assess liver function pre-operatively to try to prevent it. And after that, Nasser Mugla will go through a case that we had recently that I think does show some of the points that we will raise earlier during the discussions. So I'm going to try to share my screen. And we can just see if it works. Okay, can you just confirm that it's the right view, Cheryl?
Yes, it is.
Okay, thank you very much. All right. So I'm going to start by just showing the images of 2 cases, and this is courtesy of Dr. Min Lee, a colleague from Seoul in South Korea that I worked with quite closely for some years on functional imaging. And these are 2 almost identical patients, both of them chronic hepatitis B, and then a massive type HCC, the top one there with a tumor in the right liver, and then the bottom one with a tumor in the left liver. And both of them child PUA, so probably got the virus not on the basis, the tumor not on the basis of cirrhosis, but the oncogenic effect of the virus. They underwent the respective operations. The patient in the top row there underwent a right-sided hemihepatectomy. The patient at the bottom, a left-sided hemihepatectomy. And these were the outcomes. So the patient that underwent the right-sided hemihepatectomy recovered very well afterwards. This is a CT during follow-up. And you can see that the patient that had the left-sided hemihepatectomy, that's usually removal of a slightly smaller piece of liver, actually went into liver failure and eventually passed away due to a worsening liver failure that never recovered. So what we've learned over time now is that we quite seldom lose patients intraoperatively due to bleeding and other misfortunes during the operation, with a better understanding of the anatomy and especially the segmental anatomy of the liver, better surgical techniques, better anesthetic techniques, better post-operative care, so that the main cause of liver failure at the moment is actually post-operative post-operative liver failure. Even though the mortality for even major resections are in the single digits, and in dedicated centers, we still run into problems with some of these patients, sometimes completely unexpected. So the universal prerequisite for a liver resection, that is regardless of whether you do it for an HCC, for a cholangiocarcinoma, or for colorectal metastases, is that you want to achieve a R0 situation in the liver, and that you have to leave sufficient future liver, sufficient future liver remnant that would support the function of the patient post-operatively, and also allow for post-resection regeneration. So we're talking about a volume, but very important, it's not only about the volume. The part of liver that we leave behind has to have intact arterial and portal supply, and the biliary and venous drainage should not have been compromised. Otherwise, even if the volume of the liver may be sufficient, it will not be functioning properly. So what is a sufficient future liver remnant? The way we calculate it is to calculate the whole parenchymal volume of the liver in milliliters or in cubic centimeters. You have to subtract the tumor volume from that, and then we measure on some form of cross-sectional imaging the volume of the future liver remnant, and then we work out the percentage future liver remnant. There's never been any good randomized trials performed on that, but there was a survey study done some years ago. I show you the results here, that was sent around to centers all over the world. And if you look at the bottom line there, the overall means for the values that the people gave, we ended up with, in a patient with a normal liver, somewhere around 25–30% is regarded enough for maintaining the function post-operatively, and then allowing for the regeneration. You can already see there, they also ask what you do in cirrhotic liver. And then people just sort of went for a ballpark figure, and we ended up with 50% there. But obviously, this is not a static thing in terms of cirrhosis. We know that there are grades of cirrhosis. So what we actually have to do is, in patients with some form of liver dysfunction, that we have to account for the dysfunction. So volume-based decisions, where we can rely on purely a volume in a patient with a diseased liver, becomes obsolete, and we have to add some form of functional analysis to that to increase the volume of the liver appropriately for the level of dysfunction. So this is a problem that we face more and more. Obviously, in this meeting, with HCC, often cirrhosis is a problem. And you know that in the Barcelona criteria, we have a few surrogate markers for function, such as portal hypertension and so forth. The really reason why those are there are not so much for the problem with portal hypertension per se, but it does give you an indication of the severity of the liver cirrhosis. And then the other big group that is outside the scope of this discussion, patients with chemotherapy-associated liver injury, that we see more and more in patients with colorectal metastases that are treated with neoadjuvant or conversion preoperative chemotherapy. Just a quick background of liver function tests. One can say that the liver function test that we take every day, the blood tests, actually do not have that much to do with liver function. It does give you an impression, but they aren't particularly good. We know that the patient can have perfectly normal liver function and have a very high bilirubin due to other reasons. The enzymes as well, where cellular damage, especially of the parenchyma, will give you the rise in the cellular enzymes. I always say in a patient there where we've taken the whole liver out, there's no liver whatsoever, that patient will have a completely normal AST and ALT, although they've got absolutely no liver function. So again, it gives you some indication of the damage that has been inflicted on the liver or ongoing damage, but it doesn't really give you a measurement of the function. And then we can look at the synthetic capability of the looking at the coagulation parameters and maybe albumin, but we also know that there are a lot of other factors that can change your albumin levels. So the clearance test is sort of one step in the right direction. Icg clearance is the most commonly used. We unfortunately don't have that here in Cape Town. I know they've got it at Karolinska where Stefan is, and it's quite a useful test. And there's actually a very nice algorithm that Makuchi published some years ago, and how you use the Icg clearance to actually make your decisions in terms of what the extent of liver resection a patient may tolerate. These clearance tests are quite cumbersome. They can be a little bit expensive as well, and still the cut-off levels are not that precise. The other drawbacks of liver function tests as we know them, and that actually includes the Icg clearance as well, is that they actually measure the total liver function. And if you've got any disease where the function or the dysfunction is not homogeneously dispersed through the liver, you're going to run into problems. And I'm going to show you an example of that later. So we know that there are some segmental liver diseases, PSC, where it's based on the biliary pathology, even primary biliary cirrhosis. And then with the intrahepatic stone formation, Ascaris that we see here in Cape Town in the east, it's more Clonorchus sinensis and Opisthorchis. And then there are some diseases, alcoholic cirrhosis and Wilson's disease, that seem to have a hemiliver spread of affecting the liver. And then even diseases like non-alcohol, now it's MAFLD and MASH, and chemotherapy-induced hepatic damage is not always the same throughout the liver. We know specifically sinusoidal obstruction syndrome, where you see this sort of patchy blue liver bits on the liver surface. And then we know that function is probably not even homogeneous in the normal liver, where there may be differences between the left and the right liver. That's why we still use prognostic scoring models. The most commonly ones used, the Child-Pugh and MELD. Just to show you what the problem with that is, the Child-Pugh is more than 50 years old. Just think what telephones looked like 50 years ago and what we make our calls with today. That's how old that scoring model is. And it was actually designed for operations on patients to relieve their portal hypertension. It had nothing to do with choosing patients for liver resection. And even MEL that we often use nowadays was actually designed for prioritizing patients on the transplant lists. There are better methods, the imaging-based liver function assessment methods. There is the GSA test that is not available in Western countries. It's used in Japan, but we do have mebrofenin, that is actually HIDA, the old HIDA scintigraphy, and there's a lot of work on this has been done, especially by the Amsterdam group. That has shown to have some value. The big advantage of that is that you can sample from different parts of the liver using imaging sampling, and in a way you could account for sort of an inhomogeneous distribution of the malfunction. And then there's also functional MRI that is even a little bit more difficult, a bit more expensive, and still experimental. But what the imaging-based liver function assessment methods have shown us is that function is not homogeneously distributed through the liver. This is just an example from an article that we actually wrote on cirrhotic patients, where you can clearly see here in the hepatic extraction fraction, one of the measurements that we do, the very big difference here in the left and the right liver. We did some modeling on that, first in 10 volunteers with normal volunteers with normal liver function, where we compared a global liver function test and just worked with percentages with actually measuring the liver function in the different segments. and then comparing a future liver remnant in a simulated left hemihepatectomy. And you a left side hemihepatectomy, yes. And you can see here if people have a normal liver function, the function is quite similar to the volume, and the calculations are almost the same. But if you go to patients with liver cirrhosis, you can see that you can make a malcalculation almost with an overestimation of function in these patients of 20, almost a quarter. And I think these are the patients that we run into trouble with. So just a demonstration that we, in cirrhotic patients, that we have to be careful with purely volume measurements, and also that the global tests do not really work, because it doesn't give you an estimate of the function in exactly the part of the liver that you're going to take away. So I think that was my last slide. So I'll stop sharing and then hand over to Stefan, that will share us his ideas on managing these patients. Is Stefan still there? Oh.
I don't see him at his desk at the moment.
Let me just see where he is. I'm just going to see if I can make a call. Oh, there he is. Stefan, over to you.
So, hello everybody. Thank you very much for the kind introduction and the possibility to talk a little bit about post-hepatectomy liver failure. As Edward said or told you, I'm an HPP surgeon currently working here in Stockholm, and I have a big interest for liver failure, as we see those patients quite frequently. And just, can you confirm that you, sorry, this was obviously the wrong picture to start with. Can you see the slides?
Not yet.
Sorry, I'm going for it. There you go. Where is it? There you go. Can you see it now?
Yes, it's going to come up. There we go.
Okay, perfect. So what I like to do is to give you a short overview and some specific what I thought might be interesting for you in general, and what might be important to know. So I can't, sorry, why is it possible? And there you go. So I will give you a short overview about different aspects of PLF, including all these different aspects here. A very important thing is the etiology. Edward told you about the volume, and of course you can dig into a little bit deeper in the liver function. And the liver is a quite fascinating organ. I don't have to tell you that. Most of you are pretty aware of this. And the factors affecting liver function are quite amazing. And you have a lot of different functions that can fail and have an influence on the liver function as well. So I just showed you this publication here from Van Mierlo, which is really an excellent overview article. And you see that there just gave an overview what can contribute to liver dysfunction. And this might be, you know, every single one of these, the important thing when a patient develops postoperative liver failure. So it can has a lot of different reasons. The most important one, of course, is the small for size or situation. Therefore, it's very important to have a good preoperative workup and good volumetric. Then you always have the problem with inflow problems, and you have as well the outflow problems, means comprising the outflow via the hepatic veins or the bile ducts. Another important factor for liver failure is the risk factors. And as you can see here in an overview, the risk factors are quite different and multiple. So you have both patient-related factors, you have liver-related factors, and you have even surgery-related factors. And this is exactly the problem. Even if you do a proper workup of the patient in regards of volume and function, it's extremely difficult to exclude a post-hepatectomy liver failure 100% pre-operatively. It's just impossible. And this is always also the reason why we still see it. Another big problem is the definition of post-hepatectomy liver failure. And we will see this in the case presentation later on. You will find here some pre-operative models Edward talked about, the MELD and the Child-Pugh score. Post-operatively, we have over the years, and this is just a selection of different definitions here, we have over the years seen a lot of proposals how to define or diagnose post-hepatectomy liver failure. As you can see, most of these definitions and risk models just investigate the patient or define the patient on post-operative day 3 or later, which is quite a big problem, because if you have a patient with a severe encephalopathy or hypoglycemia already on post-operative day 1, I would say this patient has already liver failure there, but there is actually no definition covering this situation. So the definition post-operatively is a big problem. What's usually used right now, or even in publications, is more and more the ISGLS definition from the International Study Group on Liver Surgery, which actually grades liver failure in grade A, B, and C. And I will give you an overview about this a little bit later. So what are we talking about? Incidence, Edward talked about it, is very important, but as you can imagine, the incidence is of course very much dependent on what kind of definition you use. As you see here from an article from France, dependent on the definition you use, you have one time 7%, another time 14%, and in the third definition, you have an incidence of 22%. So it's extremely important to reference and to compare, not apples and bananas, but always the same definitions to get a proper impression of what, or the extent of the problem. So we did a study here in Sweden as well, where we had a look on more than 2,000 patients, and what we actually saw there, we could not define the incidence as we did not have the blood values from all those patients. But as we see, or as Edward already told you, the 90-day mortality, and this is another aspect with liver failure in modern medicine, you always have to look at the 90-day mortality, because modern intensive care units always make the patient almost live longer than 30 days with post-operative liver failure. So to cover really the in-hospital mortality or related mortality, you really have to use the 90-day mortality. And there we saw in Sweden, covering all kinds of liver resections, 90-day mortality is slightly above 2%. But when we had a look at these patients, we saw that in almost half of them, or at least in more than 40% of these patients, PLHF was the reason and the cause of death. So we identified even here in Sweden, PHLF as the most important single reason for post-operative mortality. The treatment, this is quite tricky because we have no treatment, and this is exactly the biggest problem, as this is a rather rare complication, and it's always difficult to do proper studies on complications because you never exactly know when they occur. So what you actually have is a treatment recommendation, which is very close to the recommendations of treatment for acute liver failure to any cause. So you always try to rule out jaundice. So you have to do your radiological workup, maybe have access to PTC or ERCP. You have to do, of course, hemodynamic support in case the patient is circulatory unstable. Renal dysfunction is quite normal in PH-ILF patients, so we have to look at the kidney functions. Coagulopathy is a problem. There you have to be careful because you would expect higher bleeding complications, but it's actually shown that these patients do show hypercoagulation problems and have a tendency to thrombosis. So there you really should have antithrombotic prophylactic treatment as well, despite maybe an increasing INR. And the nutrition is a very, very central aspect in those patients. And early enteral nutrition is really, really something to worth to try to achieve in these patients. And then what's another very, very important aspect, and almost all of these patients suffering from severe post-hepatectomy liver failure, they have in the terminal phase in the end some kind of infection or septic complication in their clinical picture. So the early use of antibiotics is really key in those patients to avoid this kind of complications. Ascites is quite common as well, and encephalopathy is more or less more rare complication. And this early octreotide is really not proven in a clinical study, so I cannot give you a general recommendation for this. What we did here in accordance to a suggestion here from the Amsterdam group, we did a prospective study with MARS, with the molecular adsorbent recirculating system. It's one of the commercially available liver dialysis systems. And we designed a prospective study where we put 10 patients with PH-ILF according to the 50-50 criteria. From day 5 onwards in the MARS treatment, and we applied a minimum of 5 consecutive treatments in those patients. And what we actually saw was quite a good result in those patients. It was safe, it was feasible, we could do this, and we could actually decrease the 90-day mortality quite substantially to 10% compared to 50% we usually have in those patients. Unfortunately, another randomized prospective trial has now been hampered by the COVID pandemic. So everything is prepared, but we did not manage to start the study so far. Experimentally, we have a lot of different aspects, but those aspects are very, very often just demonstrated or tested in animal models. There you have quite good models with extended hepatectomies, 90% hepatectomy in both pigs and rodents. So both liver transplantation, bioartificial liver support, stem cell transplantation, extracorporeal liver support, all these kind of treatments are theoretically beneficial for this kind of patients. But in practice, the data situation and the proof and the evidence is almost not existing. So it's still all these kind of treatments actually in an experimental stage or has contraindications of several kinds. So why is it important to have a special look on post-hepatectomy liver failure? Well, it really affects the outcome of patients. And as you can see here, even if you survive the 90-day period and do not succumb early in the postoperative phase, you do much worse when you suffered of post-hepatectomy liver failure compared to other patients. This study here compared patients with liver failure, and both the recurrence-free survival and the overall survival was negatively impacted for those patients who suffered on post-hepatectomy liver failure. So this is really an important thing, and even we did now a quite big analysis with more than 700 patients here in Sweden, where we gathered the data from two centers over a 9-year period. And what we actually saw, and this is again a definition problem, that the ISGLS-A criteria do not have a significant impact on both 90-day mortality and long-term survival. what's interesting is the ISGLS-BC, meaning or giving a situation where you both have abnormal liver sample or values, blood samples, 5 days post-operatively, and you're in need of additional interventions like inotropic treatments or antibiotic treatment, albumin support, and all this stuff. So this is unpublished data, but the manuscript is under preparation here. So for the clinical practice, what advice can I give you? I can give you, again, a complicated advice. You can have, again, a look at this publication from Van Miller, where you can find a very well detailed workup and treatment recommendation. In my opinion, it's too complicated, and for the clinical practice of a normal HBB service, liver surgical department, you can probably just reduce it to 4 major areas of interest, and this is the pre-operative prediction. So I will get back to this in a minute. You have the prevention, you have the post-operative prediction, then you actually have the management. And as you see, the management takes pretty little part of this entire algorithm. So the treatment is still, and the management is still actually, unfortunately, the most difficult part. So what I can give you as an advice, the best treatment of PHLF is to avoid PHLF. So the preoperative workup with the planning, have a look at the volume, the function. Is there cholestasis? You have to release it. Never do a hepatectomy or major hepatectomy and just leave a cholestatic part of the liver, which is unreleased, left. It will not work, I promise. A vascular engagement has to be planned meticulously. What kind of resection is needed? Do you have the competence? What else can be done? And if you don't know, be careful with major resections, because even in right-sided hemihepatectomies, the future liver remnant of the left liver is in a really substantial portion of the patients too little, and the patient has a severe risk of developing post-hepatectomy liver failure. For the intraoperative situation, really be careful with livers, avoid complications. Most of this is the bleeding. Use a Pringle. Be careful again with your preoperative bleeding, preoperative planning. Have a look at the arterial and portal anatomy, and be really afraid of vascular and bile duct injuries, as this always causes postoperative problems. And if you use the Pringle, please use it interrupted. We use it here with a 15.5-minute closed open algorithm, and this works quite nicely for us. So, and this is usually recommended in general. And in the post-op situation, just be aware of the possibility that a patient might develop PHLF. If you have immediate signs of severe PHLF, hypoglycemia, encephalopathy, the patient has to be usually transferred to the ICU. This is extremely difficult to handle on a normal ward. If you have increasing bilirubin, exclude bile duct injuries, obstructions. If you suspect some fluid collection, or even if you do not suspect them, they are, after major hepatectomy, you almost have always fluid collections. It's just a question whether you have to treat them and if they're infected or if they're not infected. But if you have a patient with an impacted liver function, you have to find and treat them, and be very aggressive with broad spectrum antibiotics to avoid septic complications. And in the end, avoid hepatotoxic drugs. This is actually another part. Well, I hope this gave you quite a short overview about the most important aspects which PLF might cause, and thank you for your attention.
So thank you very much, Stefan. We're going to go over to Nasser shortly. I just want to ask you a question, or I can actually just have a look at the questions in the chat here. Do you assess the portal pressure before surgery? And if you do that, how?
We do not regular a portal pressure assessment. We would like to have it, but it's quite difficult for us to do a wedge pressure measurement. So what we actually looking for now is to develop radiological techniques to have a indirect assessment of portal pressure. But what we always do in or if there is suspected cirrhosis or HCC, that we always do some liver function workup, but we do not assess specifically the portal pressure, more than that we of course look for indirect signs of portal hypertension like varices and splenomegaly.
Okay, these questions are all from Hala Abdallah. Another question, any use of elastography of liver stiffness before surgery? Does that give you any help or an indication of where we are in terms of liver function?
Yes, our Department of Hepatology does this when we have suspicion of HCC. The problem is that, in my opinion or in our experience, this measurement is not that reliable, unfortunately, especially if you have large tumors. You will always end up with false positive high measurements there, because the tumor always has a higher resistance than the surrounding liver tissue has. So you have to be very, very careful when you use this, and you can use it, but I would not rely just on the liver stiffness measurement.
And just the last, I see there's a question from Mark Sondrup as well. Is there any association between the underlying cause of liver disease? So in other words, alcohol, hepatitis B, C, and the risk of post-operative liver failure?
The problem is that you have so few patients in the end anyway who really develop severe PHLF that this is extremely difficult to make such subgroup analysis. But in general, the problem is, and I think the case which will be presented soon will illustrate the problem. Even if you do a proper workup, if you have a kind of hepatitis, if you have a kind of cirrhosis, fibrosis, steatosis, chemo-associated liver injury, it makes it extremely difficult to exactly determine how much volume you have to leave in the patient. And in all these patients, I would say the risk is much higher, that you see really completely liver healthy individuals developing a tumor and developing afterwards liver failure, in my opinion, is quite rare.
Yeah, so I mean, I think the question is also a little bit relevant in the sub-Saharan African context, where hepatitis B with the dual pathways to hepatocellular cancer, we see these very young patients where they do not have cirrhosis. They may have a little bit of fibrosis, but they develop the tumors in normal livers, whereas hepatitis C, they usually have to go the cirrhosis pathway. I don't know, Mark, if you want to comment on that. Hepatitis C, as far as I know, just the presence of hepatitis C, if there's not cirrhosis or at least fibrosis, that it wouldn't really affect the liver function. I don't know if you've got a different opinion or more information on that.
No, Ed, no, you're right. Obviously, Hep C invariably, if it's going to produce problems such as HCC, which is the most likely reason for resection, it's going to be in the more advanced fibrosis or cirrhotic liver. I was just interested whether there's any data to suggest that the underlying cause actually is, predicts for slightly higher risk, apart from obviously, the volume issues. But clearly, I hear what Stefan's saying. The numbers are quite small. Thanks, Stefan.
Just the last question before we go to the case, Stefan. So if you have a patient that is heading for liver failure and you see all the worrying signs, what is in practice your workup of such a patient? The patient is in a high care unit or an ICU, and you see that the bilirubin and the INR are really going off. So what is the routine that you follow to work up these patients to look if there's anything that you can improve on this patient?
Yes, it's actually those points I should have marked maybe a little bit more distinct. You always have to do a CT on these patients. You have to exclude inflow problems. You have to exclude outflow problems. So you have to be sure that there is not a vascular problem in the liver. you have to be sure that there is no bile duct injury, bile leakage. You have to be sure that there is no fluid collection. And these are the most treat. If you have if you can exclude all this kind of complications, unfortunately, you have kind of tied hands, because then you have not so much left more than symptomatic or medical support. But all of these complications have to be addressed, whether by reoperation, intravascular treatment aspects, or I don't know what, but the patient should not have fluid collections. The patient should not have untreated bile leakage. And of course, the patient has to have a sufficient arterial, portal, and liver venous, kind of state.
Okay, thank you very much. I think we can carry on now. Wendy, so she'll just take this question quickly. HCC in NAFLD without cirrhosis might have increased risk for PHLF. Yeah, I think that we can actually relate to that in this case that's coming up. That I think it's not a NAFLD case, but I think there was a problem that may be similar to the question that you posed. So let's just move on to the case presentation. So Dr. Nasser Mughla is a fellow in the hepatopancreatability unit here in Cape Town, doing a subspecialization in HPB surgery, and he's just going to present a case that we've had recently. So Nasser, over to you.
Okay, good afternoon, colleagues. Thank you, Prof. So I'm gonna share my screen. Can you see my screen?
Not yet.
Prof. Prof, can you see my screen? Prof?
You're not
Prof,
sharing yet?
Can you see my screen? Can you see my screen? Just 1 second.
It's all good. You can continue.
Now it's fine, yeah.
Okay. All right, so I'm presenting a patient that we saw in our clinic, and hopefully we can have a productive discussion around the case. So we saw this patient. He's a young a man in his 53 of age. He's a chief. He's originally from Taiwan. With the social use of alcohol, no significant medical, and chronic hepatitis over hepatitis B over 20 years. He was initially treated with interferon, then he defaulted follow-up, and he's not on HCC screening. He's also diabetic on insulin. Hospital presented with 6 weeks history of in summary, referred to as well
Ed, are you there?
of
The sound is, Nasser, the sound is quite bad. We can't hear you.
failure and
Ed?
Yeah, I hear you. I couldn't hear him either. He's just changing his position to see if we've got a better.
Can you mute? Yeah, sorry. So in summary, so this patient is a 53-year-old man with an HCC on a setting of chronic hepatitis B for more than 20 years. No other significant medical history. His performance status of 1, and he had no stigmata of chronic liver failure or any evidence of portal hypertension. He had normal liver and kidney functions and has gastroscopy done before he was referred to our MDT, which showed no severe varices. He had a CT scan and MRI, and the reason we did the MRI was just for further characterization of the liver lesions. So we have a dynamic videos here of the MRIs, which we're gonna go through here with you. So this is uncontrasted T1 MRIs. So going down, you can see there is a hypo-intense lesion in segment 7. It's about 5 by 3.5 centimeter. And going further down, we can see 2 other lesions, which they are heterogeneous intensity, mainly hypointense, with some area of hyperintensity might be related to bleeding to the lesion. Otherwise, there are no other lesions in the left liver, and the liver generally looked okay, with maybe an impression of irregularity on the surface of the liver. And this is the arterial phase. On the arterial phase, we can see there is a, sorry, this is the arterial phase. And you can see there is enhancement, marked enhancement in the lesion, the one in segment 7, but less so in those in segment 6 and the one between segment 6 and 5, with some nodular enhancement. And looking at the anatomy of the artery, it looks like normal anatomy, with both right and left hepatic arteries coming from the proper hepatic artery. And on the second, on the next MRI, so this is the portovenous phase. We can see a classical washout of the contrast from the 3 lesions, and they looks like hypo-intense in comparison to the rest of the liver. And in the last delayed 20 minutes delayed MRI, we can see there is a retain of the primavest in the hepatocyte, and complete washout hypointense lesions in the right side of the liver. So we thought that now we have like a history of the patient and a clinical assessment and examination and the imaging. So we wanted to ask the people in this platform if what they think the option for this patient, would they go with a palliative intent or a curative intent for this patient. So we're gonna play a poll and we need you guys to answer. And we see we have a next another question in the next slide. So can we play the poll, please?
You just have to relaunch the poll. There it goes now, yeah?
So 78% of the audience went with the curative intent. 22% went with the palliative intent. So we thought in our MDT, this patient has 3 lesions. They're all on the right side of the liver, and he had segment 2 and 3, segment 4 A and B, which they're usually enough for the patient to survive. So we went with a curative intent. So the next question is, in terms of curative intent, would you go with resection, microwave radiofrequency ablation, or with transplantation? Just have maybe another 10 seconds for everyone to answer. Okay, so that's great. Like 83% the audience went with the resection. 13% went with microwave ablation, and 4% went with the transplantation. So we thought this patient actually is out of San Francisco criteria for a transplantation. So the decision in MDT was not to offer this patient transplant. We went with resection. And the reason we didn't go with radiofrequency ablation is basically because the size of these tumors are quite big. There are about 2 of them around 5 centimeters. And for the microwave or radiofrequency ablation, we think it's maybe appropriate for lesions around 3 centimeters. So in our MDT discussion, we decided to do a right-sided hemihepatectomy for the patient. But given the long-standing history of hepatitis B and possibly hypertrophied segment 2 and 4, there is a concern about the quality of the future liver remnant. So biopsy of the normal left liver was recommended. And this is the result of the biopsy. So the biopsy came back and showed that there is fibrosis in the left liver or the future liver remnant. So from here, we thought about that we need to have some volume manipulation. And so the patient, we wanted more information. So we did some liver volumetric assessment. And here are some of the measures that we have. We use the FOTI formula. The estimated liver volume was 1,789 cubic centimeter, and the future liver remnant was 605. And this is about 34%. So there's still concern about the future liver remnant. So the decision was to proceed with the portal vein embolization, which was performed, and the plan to review the patient after 3 weeks to assess for hypertrophy. So this is just a CT scan done 3 weeks after the embolization, and we can see that there is an increase in the size of the left lobe of the liver, segment 2 and 3 and segment 4, and we achieved about 55%. So the future liver remnant now representing about 55% of the total liver volume. So we didn't do the kinetic growth measurement, volume measurement, because this was 3 weeks from the initial embolization, and that usually preferred to be done in the first week. So the patient went for surgery. So what we do usually here, we do a selective inflow control. We seldomly use Pringle's maneuver, and we use a COSA for parenchymal dissection, and we leave the hepatic vein last. There were no concern intraoperatively. The total blood loss was about 500 mils. We left closed suction drains, and the patient didn't require any blood transfusion intra-op. So post-operatively, we usually like routinely, our patient will go to PACU, which is the post-anesthetic care, a high care unit, and they will receive a standard care in an open procedure. They will get a pain management team involved. And what we noticed with this patient in the first 3-4 days, there was a progressive increase in his bilirubin and INR, as you can see, and the peak was around day 4, day 5, and also increase in his INR. So we thought, after we excluded other issues, which I'm going to go through in the next slide, we thought this is consistent with a liver failure, and Icg definition, as we alluded to earlier. So if you have any increase in the INR or serum bilirubin concentration above the normal value in your lab in day 5 or more, that considered a post-resection hepatic resection liver failure. And there are 3 grades. So in our case, I'm going to tell you what happened exactly. So the grades are, if you have no intervention, you just manage the patient expectantly. So that's grade A, and grade B if you require intervention or a change in the patient management plan without invasive intervention. And then C when you require to do an invasive intervention. So in our patient, day 5, he spiked temperature of 38, his white cell count was 16, and his CRP went up to 150. But he preserved his renal function. So we did septic screen, we did chest X-ray, we sent urine, we checked his wound, his line, and we started empirical antibiotics as preserved renal function. We put on peptaz and amikacin. Then we monitored the output from the drain. There was no bile, but it was minimal. So there was a concern that maybe there is a blockage of the drain. And the patient had a CT scan, which didn't show any evidence of thrombosis, but he had a large fluid collection in the right hemihepatectomy liver bed that's compressing the left hemiliver. So what we did is we booked the patient for percutaneous drainage, which was done. And what came out was just a fluid. There's no bile leak, and it wasn't pus, and the MCNS was negative for bacteria. So the diagnosis of post-hepatectomy liver failure was made, and the patient improved after the decompression, and his bilirubin and INR returned to the baseline maybe in 2 weeks from the initial procedure. So I think if we have any question about the patient, or we need any discussion around the case, we can do it. This is the end of the presentation.
So thank you very much, Nasser, for a very nice presentation. I'm just going to have a look at the chat group here, just to catch on Wendy Spearman's question here. HCC in NAFLD, she spoke about without cirrhosis might have increased risk for post-hepatocellular liver failure. And I think in this patient that did not have cirrhosis but where there were signs of fibrosis, according to the pathologist, that may have put the patient sort of in a risk zone. And certainly the post-operative complication didn't help. So Wendy, if I may ask you, dysfunction in patients with fibrosis, is that detectable by any method or by any means?
What's the question?
Yeah, no, I just want to ask Wendy Spearman that posed the question. I'll just see if she's still on. Is Mark Sonderup still on? Mark, you want to take it? I can't see if Wendy's on.
Yeah, sorry, your question is around, I see Wendy raised the issue around steatosis in patients, and whether that is an increased risk. I would think it probably is. As for the fibrosis issue, your question, sorry, I just needed to understand it better.
No, first of all, sorry, the question of steatosis, but then if fibrosis, if there's any, what your opinion is about the function in a patient with only fibrosis and no cirrhosis yet. Is there any way that we can detect that other than a biopsy? And what do you think is the impact on liver function?
Oh, advancing fibrosis clearly must correlate with, and Stefan can help here, but advanced fibrosis must correlate with increased risk of PLF. But obviously, in this particular patient, I think a FibroScan would have been very useful, because, you are assessing a far larger portion of the liver than a biopsy, which, although the gold standard is, as we've discussed before, subject to potential limitation or inaccurate estimation. So I wondered if a FibroScan wouldn't have actually helped here somewhat preoperatively.
Yes, no, thanks, Mark. Listen, yeah, sorry, and then just one other question that came up here. Post-op, sorry, there was a question about the treatment of hepatitis B. Nasser, if I remember correctly, this patient had a very low viral load, almost undetectable. Is that right?
That's correct, Prof. Yeah.
So this patient wasn't on hepatitis B treatment at the time, but Mark, do you think this patient should go onto hepatitis B antiviral treatment after his resection, even if he's got a very low count?
Yeah, and I think in this instance, the count is probably irrelevant. Ed, I happen to know the patient, and he was started on oral antiviral therapy pre-everything, which would have been the appropriate time to start it.
Okay.
Ideally going into resection, you would probably want him as suppressed as possible.
Yeah, Mark Benon wrote that summary, so he just didn't give us that little detail.
Okay.
And then there's a question post-op: do you give amikacin do you give amikacin given the possibility of hepatorenal syndrome in patients who have post-hepatectomy failure? I can maybe boil this question to Stefan. Stefan, are there drugs that we should avoid completely in these patients? There's a question about amikacin here.
Well, antifungal medicine, and I think amikacin is one of these.
Amikacin is anaerobe gram-negative covered.
Yeah. Okay. Sorry. So this is usually with the antibiotics. I think, of course, there are a few with a little bit increased hepatotoxicity. We always double check actually with our hepatologist in this case, because usually things you can give to liver sick patients, you can give to patients in this situation as well. And I mean, it's the same with paracetamol or something. I mean, the experience and the usage of paracetamol is so conflicting postoperatively. And our hepatologists, for instance, give it to everybody, and we are very, very reluctant and careful with this. So, but the evidence for that is extremely low. I think what's really an important thing is the parenteral nutrition, where you really have to be careful with your fatty acids, and so and you don't stress the liver unnecessarily. So this is really an important point to look for and go for enteral nutrition, even with feeding sons or something like that. But if you have to treat a infection, I think you have to do it. And there are just some antifungal medicines, but I do not remember exactly what the name is internationally for them. So you might be a little bit careful, but usually fungal infections come in a later stage of this postoperative complication.
Okay, I think we're just over time. So if there are not any more questions, we can actually conclude. If there's anybody that's got a question remaining, just put it in the chat group or unmute and ask the question. And if not, I'm going to conclude. First of all, just to thank the speakers. Thank you very much to Stefan for taking the time to join us for this meeting and a very, very nice presentation. And also Nasser for summarizing a case that he was actually not really involved in and had a little bit of secondhand information there. Then again, ECHO, University of New Mexico, and the Gastro Foundation. There is that we have to thank. You can leave some comments as well afterwards on the format of the meeting. As I said, we like to run these meetings in a MDT format. So if you have got interesting cases from other countries in Africa, feel free to fill in that form. We did mail it out before, just with a summary of the patient. You can send us the DICOM files. We will have them assessed by a radiologist and put them in a de-identified format, and we can show the imaging actually from here. And we really will be happy to get some interesting cases, because I'm sure you have some of those. And then thanks to Cheryl and Karen. And then also next week's meeting, I've been told, is the lower GI meeting, and it will be about polyps and polyp detection and histological aspects of colon polyps. I'm just going to check if there's anything more in the chat group. There were a few things more. Just a comment about amikacin that is not friendly with the kidney. We see that. And the antiretroviral, Mark, which one was used? Was it lamivudine or tenofovir? Mark is maybe not with us anymore. In any case, it will be one of those two.
Lamivudine, Prof.
Okay,
thanks. Yeah.
Okay, so thank you again for everybody joining, and have a nice day. Bye.